Before you dive into the chaos of blood-soaked canvas and the race against time, hit that subscribe button because this is a story of minutes mattering more than medals, of ordinary men and women building a lifeline across a continent at war. And you won't want to miss what comes next. The tent walls snap in the November wind, rain hammering the camouflage netting overhead, and inside the casualty clearing station 3 miles behind the Hurtgen forest front, Captain James Reardon presses both hands into the abdominal cavity of a 19-year-old rifleman whose name he does not yet know, trying to find the bleeder before the plasma runs out. And in this moment, the entire Allied medical evacuation chain converges into his fingertips, into the sweat running down his surgical mask, into the nurse beside him, calling out blood pressure numbers that drop with every shell burst, shaking the ground outside. The boy on the table, dog tags reading Morrison, Thomas, O positive, arrived 17 minutes ago on a stretcher lashed to a Jeep hood, and those 17 minutes are the difference between a name on a telegram and a son coming home. But to understand why Reardon is here at all, why Morrison is still breathing, we have to rewind 6 hours and follow the chain link by link, person by person, vehicle by vehicle, from the moment a German shell fragment tore through Morrison's gut and a forest so dark the trees swallowed the sky. It begins with the aide man, the combat medic crouched in a foxhole 20 yards behind the rifle company, listening to the incoming. And when the barrage lifts and someone screams, "Medic, medic, medic," he's up and running low through the shattered pines, carrying a canvas musette bag that weighs 11 pounds and contains everything he has to keep a man alive for the next 30 minutes. Morrison is on his back in the mud, knees drawn up, hands clutching his abdomen, and the aide man whose name is Kowalski cuts away the uniform, sees the entry wound left of the navel, no exit, abdomen rigid, and in 15 seconds he has dusted sulfa powder into the wound, placed a field dressing, given a quarter-grain syringe of morphine, and marked Morrison's forehead with an M and wax pencil so no one downstream gives him another dose and stops his breathing. Kowalski does not try to move Morrison alone because 2 men carry faster and smoother than 1 man dragging. So he signals another medic, and together they slide Morrison onto a litter, a canvas stretcher with wooden poles, and they begin the carry back through the trees, stepping over roots, ducking branches, moving as fast as terrain and enemy fire allow. And every stumble sends a jolt through Morrison's torn peritoneum. But staying still means dying, so they move. The battalion aid station is a sandbag dugout 200 yards behind the line, marked with a red cross on white canvas that the Germans sometimes respect and sometimes do not. And here Captain Levy, the battalion surgeon, has space for 6 litters on the dirt floor, a folding table, a Coleman lantern, and supplies that arrived yesterday in a Jeep trailer. Levy examines Morrison in less than a minute, notes the rigid abdomen, the thready pulse, the pallor, and he knows this is a surgical case, knows the boy needs a laparotomy within 2 hours, or he will die of shock and peritonitis, and the aid station has no capacity for surgery. So Levy starts a plasma drip, gives a second syringe of morphine because the first is wearing off, records the findings on a field medical card tied to Morrison's jacket, and sends him to the Jeep idling outside, engine running, blackout headlights taped to slits. The Jeep driver is a Texan named Hollis, who has been shuttling wounded for 3 days straight, grabbing sleep in 15-minute intervals, and he lashes Morrison's litter across the hood brackets, climbs behind the wheel, and accelerates down a forest track turned to soup by rain and tank treads, no lights, navigating by memory and moonlight, and twice he swerves into ditches to avoid incoming fire. And each swerve is agony for Morrison, but the alternative is a shell through the engine block. And 4 men dead, so Hollis drives. The collecting point is a farmhouse cellar a mile back, where a holding station sorts casualties by priority. And here Morrison waits 20 minutes on a litter in a line of other litters, groaning men and silent men, while a triage officer, a captain with the look of a man who has not slept in a week, moves down the row making chalk marks on foreheads. Immediate, delayed, minor, expectant, and Morrison gets an eye for immediate because his blood pressure is dropping and his abdomen is distending, and that chalk mark moves him to the front of the ambulance queue. The ambulance is a Dodge WC-54, a 3/4-ton truck with a red cross on white, and it can carry 4 litters stacked in racks or 7 sitting wounded on benches, and today it carries 4, including Morrison. And the driver, a corporal from Ohio, has orders to reach the clearing station 5 miles west before the road gets shelled at dusk. So he pushes the Dodge hard over cratered roads, gears grinding, suspension bottoming out, and inside the canvas-top bed Morrison and 3 others slide and jostle on their litters, for bottles swinging from overhead hooks. And one man is crying for his mother, and another is silent because he is dead, but no one has noticed yet. And the corporal keeps driving, because stopping does not save lives, arriving does. The casualty clearing station is a cluster of tents in a field, marked with red crosses the size of bedsheets, and it is the first point in the chain where real surgery happens, where abdomens are opened and skulls are trephined and limbs are amputated, and it sits just beyond German artillery range, usually, though that range is always shifting. Morrison arrives at the receiving tent, where a nurse, Lieutenant Sarah Chun, triages incoming litters, and she sees the chalk eye on Morrison's forehead, sees the distended abdomen and the dropping blood pressure, and she fast walks him to the resuscitation tent, where Captain Reardon is finishing another case, a chest wound, and Reardon glances at Morrison, reads the field medical card, and says get him prepped. And within minutes Morrison is on the surgical table under ether anesthesia, administered by a nurse anesthetist who talks him down by counting backwards, and Reardon is scrubbing his hands in a basin of water heated over a kerosene stove, and outside the tent the rain has turned to sleet, and the temperature is dropping, and somewhere in the forest the next barrage is being loaded into tubes. Reardon opens Morrison's abdomen with a midline incision, and what he finds is what he expected, a perforated small bowel, contamination throughout the peritoneal cavity, blood pooling in the pelvis, and he works quickly, clamping bleeders, resecting the damaged bowel, performing a temporary colostomy, because primary anastomosis in a contaminated field is a recipe for sepsis and death, and he irrigates the abdomen with saline, leaves drains in place, and closes the fascia and skin in layers. And the whole operation takes 90 minutes, and Morrison is still alive, still breathing. And that is a victory measured in hours borrowed from death. After surgery, Morrison goes to the postoperative tent, where nurses monitor vital signs and change dressings and administer penicillin every 3 hours, the miracle drug that has cut infection rates by half, turning wounds that would have killed a man in the last war into wounds a man survives, and Morrison will stay here 12 hours, stabilizing, before the next link in the chain. To understand why this chain works, why Morrison's survival rate is 3 times better than his father's would have been in 1918, we have to zoom out and see the system as a whole, the deliberate architecture of echelons and timings and transport links, built by planners who studied the last war's failures and vowed to do better. The principle is simple: push surgery forward and push evacuation backward, get the wounded to definitive care within the golden period, the 6 to 12 hours when shock is reversible and infection is preventable. And do it fast enough that a man does not bleed out waiting. The Americans call their system a chain of evacuation. The British call it the Medical Services Organization, but both rest on the same logic: multiple echelons with clear functions, each echelon closer to the front doing less, and passing the patient rearward faster. And the tempo is everything, because in wartime is tissue, and tissue is life. On June 6, 1944, when the invasion hit the Normandy beaches, the chain did not yet exist. It had to be built under fire, and the first hours were chaos. Aid men waiting ashore with rifle companies, treating wounded in shell craters and behind wrecked landing craft, and the battalion aid stations were dugouts in the dunes, and the collecting points were anywhere a jeep could reach, and the clearing stations were still on ships offshore because the beaches were too hot to land them. On Omaha Beach, where the plan collapsed under German fire, wounded lay in the surf for hours, some drowning as the tide came in, and the evacuation bottleneck was so severe that LSTs, the big landing ships, were pressed into service as floating hospitals, surgeons operating in the tank decks while shells hit the water outside. And it took 3 days to clear the backlog, 3 days when the survival rate was anyone's guess. But the planners learned fast. They pushed the clearing stations ashore on D+2. They built evacuation strips for light aircraft on D+5. They laid pier steel planking runways inland on D+10. And by the time the breakout came in late July, the chain was functioning, wounded moving from foxhole to operating table in under 6 hours, and the survival rate for abdominal wounds had climbed from 50% to 70%, a jump that meant thousands of men lived who would have died a week earlier. The Falaise pocket in August tested the chain in a different way, not with the chaos of invasion, but with the crush of pursuit. American and British forces closing a noose around two German armies, and the fighting was vicious, close range, villages changing hands 3 times in a day, and the wounded came in floods, more than the forward echelons could handle, and the clearing stations worked around the clock, surgeons sleeping in shifts on litters between cases, and the problem was not the surgery, it was the backhaul, getting the postoperative patients rearward to make room for the next wave. And here the innovation was the hospital train, converted boxcars with litters stacked 4 high, each train carrying 300 patients, running on repaired French rail lines from the pocket back to the coast, and the trains ran at night with blackout curtains and armed guards because German aircraft still prowled, and inside the cars nurses walked narrow aisles checking pulses and changing dressings by flashlight, and the ride took 8 hours, and every jostle was pain, but it worked. It kept the pipeline flowing, and Morrison's counterparts in Falaise had a better chance because of it. Operation Market Garden in September was the chain's greatest challenge, a narrow corridor 60 miles long. British and American paratroopers dropped behind German lines. The corridor a single highway under constant attack, and the wounded had to be evacuated down that highway or they were lost. At Arnhem, the British Airborne Division was cut off, surrounded, and their casualty clearing station, set up in a hotel, ran out of supplies on day 3, morphine exhausted, bandages torn from bed sheets, surgeons operating without anesthesia because the stocks were gone, and the wounded who could not be evacuated when the division surrendered became prisoners, and some lived and some died in German hospitals, and the lesson was brutal. Airborne operations stretched the chain to breaking, and when the chain breaks, men die not from their wounds, but from the system's failure. In the corridor itself, the evacuation route was a shooting gallery, German tanks firing on ambulances, and the Geneva Convention's promise of protection proved hollow, and drivers learned to move at night, lights off, or in convoys with armed escorts, and still they took casualties, medics and nurses killed in vehicles marked with red crosses, and the ugly truth settled in, that in total war the enemy does not always respect the symbols, and survival depends on speed and luck in equal measure. The Hurtgen Forest and the Battle of the Bulge in late 1944 brought Morrison's case into being, and they showed the chain at its most strained, fighting in terrain that swallowed jeeps and hit aid stations and turned every evacuation into an ordeal. In the Hurtgen, where Morrison was hit, the forest canopy was so thick that air evacuation was impossible, no clearings large enough for a light plane, and the only route out was by jeep or ambulance on roads that were knee-deep mud and lined with mines, and the carry time from the front to the battalion aid station averaged 40 minutes, twice the doctrinal standard, and every minute added was a minute subtracted from the golden period. The clearing stations, positioned in villages just behind the forest, ran out of tentage because the mud would not hold stakes, so they commandeered houses, turning parlors into operating rooms and bedrooms into wards, and the surgical teams worked in rooms lit by gasoline generators and heated by scavenged stoves, and the smell was blood and ether and gangrene, and Reardon and his peers operated until their hands shook, taking 30-minute breaks to eat cold rations, and then back to the table, because the alternative was triage by exhaustion, sending salvageable cases to the expectant corner because there was no capacity left. When the bulge broke in December, the surprise German offensive through the Ardennes, the chain was overrun in places, clearing stations evacuated under fire, wounded loaded onto trucks in the middle of surgery, incisions packed with gauze and closed temporarily, and the retrograde movement was a nightmare of roads clogged with retreating units and refugees, and the wounded mixed in, and some ambulances were captured, some were destroyed, and the calculus shifted from how fast can we move them to can we move them at all. But the system adapted. Field hospitals leapfrogged rearward to new positions. Evacuation hospitals in Belgium swelled to twice their capacity. General hospitals in France prepared for a surge, and the British sent hospital trains and ambulance convoys south to help. And the chain bent but did not break. and by January, when the counteroffensive began, the flow was restored. And Morrison's case in late November was proof that even under the worst conditions, the chain could still save lives. The Rhine crossings in March 1945 were the chain's final exam, a set-piece assault across a river half a mile wide, under fire, with wounded needing evacuation from the far bank back across water under German observation. And the solution was a mix of ingenuity and brute logistics. The first wave of wounded came back across the river in Ducus, the amphibious trucks that could swim the Rhine and drive up the far bank, and medics rode in the Ducus treating casualties during the crossing, starting IVs, applying tourniquets, and some Ducus took direct hits and sank with everyone aboard, and the calculus was cold. Every DKW lost was 6 or 8 wounded who would not make it back, but the missions continued because stopping meant leaving men to die on the enemy shore. Once the bridgeheads were secure, engineers threw pontoon bridges across, and ambulances rolled over the swaying spans in convoys, and the clearing stations set up on the east bank within 12 hours of the crossing. Tents pitched in German towns, still smoking from artillery fire. And the surgery began again. The same wounds, the same race against shock and infection, but now the direction was east, the chain stretching deeper into Germany, and the end was in sight. To understand the difference between the American and British systems, it helps to follow a hypothetical British casualty through their parallel chain, where the terminology is different but the logic is the same. A Tommy hit in the same action as Morrison is collected by a stretcher-bearer from the regimental aid post, the British equivalent of the battalion aid station, where the regimental medical officer, the RMO, provides immediate care, and then the casualty moves by ambulance car, a British-built vehicle similar to the American Dodge, to an advanced dressing station, and from there to a casualty clearing station, which in British nomenclature is called a field ambulance when it is mobile, and a CCS when it is static, and the surgery happens at the main dressing station or the CCS, performed by Royal Army Medical Corps surgeons working under the same time pressure as their American counterparts, and the postoperative evacuation runs through field hospitals and general hospitals back to the coast, and then by hospitals shipped to England. And the transit time from wound to surgery is similar, 4 to 8 hours in optimal conditions, longer when the fighting is heavy, and the innovations are shared penicillin, blood transfusions, delayed primary closure, the techniques that turn mortal wounds into survivable ones, and the cooperation between American and British medical services is seamless, casualties crossing from one system to the other without a hitch, because the goal is universal: save the man, not the doctrine. The innovations that made the difference were not just surgical, they were logistical and pharmaceutical, and they were learned through bitter experience and rapid iteration. Penicillin, the antibiotic discovered in 1928 but not mass-produced until 1943, reached the front in late 1944, and its impact was immediate, reducing the infection rate in compound fractures from 60% to under 10%, and suddenly wounds that had meant amputation became wounds that healed, and Morrison's survival is partly penicillin's work. Doses given every 3 hours in the postoperative tent, killing the bacteria that would have turned his perforated bowel into overwhelming sepsis. Whole blood, as opposed to plasma, arrived in refrigerated containers flown from England, and it transformed shock management, because plasma expands volume but does not carry oxygen, and a man in hemorrhagic shock needs red cells, needs oxygen delivery to tissues, and whole blood provided that, and the blood supply chain was its own miracle. Donors in England, blood typed and cross-matched and flown to France in insulated boxes packed with ice, delivered to clearing stations within 48 hours of donation, and the transfusion teams at the CCS ran blood through filters and warming coils and into Morrison's veins, replacing what he lost, buying time for his bone marrow to make more. The surgical doctrine evolved as well, and the key was learning what not to do. Learning that primary closure of contaminated wounds led to gas gangrene and death. Learning that debridement, the cutting away of dead tissue, was more important than suturing. Learning that a temporary colostomy was safer than a bowel anastomosis in the field. And these lessons were written in the deaths of men who received the old treatment and the survival of men who received the new. And the doctrine spread through surgical bulletins and conferences and word of mouth, and Reardon's technique on Morrison's abdomen reflects a year of collective learning, the wisdom of hundreds of surgeons distilled into a protocol that maximizes survival. The anesthesia improved too, from ether and chloroform to safer agents, and from drop administration by minimally trained personnel to trained nurse anesthetists who could manage airways and monitor vital signs. And the difference was fewer deaths on the table, fewer cases of aspiration and respiratory arrest, and Morrison's anesthetist, a lieutenant who learned her trade in a 6-month crash course, kept him alive through the surgery with a skill that would have been rare a year earlier and was now standard. The air evacuation was the chain's fastest link. A C-47 transport stripped of seats and fitted with litter racks, flying wounded from airstrips near the front to evacuation hospitals and rear areas, and the flight took an hour, a journey that would take 12 hours by ambulance, and the patients who flew were the ones who needed specialist care, neurosurgical cases, severe burns, maxillofacial trauma, cases beyond the capacity of the clearing stations, and the flight nurses who staffed the aircraft were trained in high-altitude physiology and in-flight emergency care, and they worked at 10,000 feet in unpressurized cabins, oxygen masks on, watching for signs of shock exacerbated by altitude, and some flights drew German fighters and some landed under fire. But the evacuation continued because the alternative was letting complex cases die for lack of specialist intervention. Morrison will not fly. His abdominal case is routine for the CCS, but he will benefit from the air evacuation's existence because it clears beds in the evacuation hospitals, freeing capacity for cases like his when he moves to the next echelon. The human cost of running the chain is harder to quantify but impossible to ignore. The exhaustion of surgeons who operate for 20 hours straight, the moral injury of triage officers who send expectant cases to a corner to die because resources are finite and choices are brutal, the trauma of nurses who hold the hands of boys their own age as they slip away, the guilt of medics who could not reach a wounded man in time, and these costs accumulate, invisible wounds that do not bleed but do not heal. Reardon, finishing Morrison's surgery, strips off his gloves and mask and walks outside into the sleet, and he stands in the cold for 5 minutes, breathing, trying to shake off the image of the previous case, a head wound, a boy from Kansas who died on the table despite everything, and Reardon knows he did all he could, knows the wound was unsurvivable, but the knowing does not help, and he lights a cigarette with shaking hands and then goes back inside because there are more cases waiting. Chun, the triage nurse, learns to make decisions in seconds, learns to trust her instincts because hesitation kills, but the decisions haunt her, the faces of men she sent to expectant, men she judged too far gone, and she wonders if she was right, if another nurse would have chosen differently, and the doubt is corrosive, but she keeps triaging because the wounded keep coming. The measurable impact of the chain is written in survival statistics, cold numbers that represent warm lives, and the numbers are remarkable. For penetrating abdominal wounds, like Morrison's, the survival rate in World War I was under 50%, and in World War II it climbed to 75%. And the difference is the chain, the speed, the surgery, the antibiotics, the blood, the accumulated wisdom of military medicine driven by necessity and measured in saved lives. For compound fractures, the improvement is even more dramatic, from a 50% amputation rate to under 20%, because penicillin prevents the infections that force surgeons to cut, and because better debridement and delayed closure keep tissue viable. For chest wounds, for burns, for head trauma, the pattern repeats, survival rates climbing, disability rates falling, and Morrison is a data point in this larger story. One life in millions, but to Reardon and Chun and Kowalski and Hollis, he is not a data point. He is a name, a face, responsibility, and they will carry that responsibility long after the war ends. Morrison moves to the next echelon 36 hours after his surgery, loaded into an ambulance convoy heading to an evacuation hospital 20 miles west, a tented facility with a surgical capacity 10 times larger than the CCS, and here he will stay a week, recovering, receiving more penicillin, eating soft foods as his bowel begins to function again. And then he will move again, by hospital train to the coast, by hospital ship to England, by hospital in England for months of convalescence. And eventually, if infection does not take him, if pulmonary embolism does not kill him, if luck holds, he will board a troop ship for New York and then a train to Ohio and a taxi to a house where his mother will open the door and see her son alive, and she will not know the names of the men and women who saved him, will not know about Kowalski or Levy or Hollis or Chun or Reardon, will not know about the plasma or the penicillin or the C-47s or the Dooku's, will only know that her son came home. And that is enough. The logistics that supported the chain were staggering. A supply line stretching from factories in America and Britain to foxholes in Germany. And every link had to hold or the chain failed. Penicillin production ramped from laboratory batches to industrial scale, pharmaceutical companies retooling to manufacture millions of doses. The drug shipped in refrigerated containers, distributed through medical supply depots, trucked to field hospitals, and delivered to medics and nurses who administered it according to protocol. And the entire pipeline had to function without break, because penicillin has a short shelf life, and a missed shipment meant infections that could not be treated. Whole blood required an even more complex chain. Donors recruited, blood collected, typed, stored in refrigerated depots, flown or shipped to the continent, and delivered to transfusion teams within days, and the cold chain could not break or the blood spoiled. And the logistics officers who managed this, who tracked inventory and arranged transport and requisitioned refrigerators, are as much a part of Morrison's survival as the surgeon who operated on him. The surgical instruments and supplies required constant replenishment. Scalpels and hemostats and suture and gauze and ether and morphine and sulfa powder. And the forward units ran on stockpiles that could last a week or two under normal operations and a day or two under surge. And the supply convoys rolling forward were themselves targets. Trucks shot up, depots bombed, and the redundancy built into the system, the multiple echelons and alternate routes, was what kept the chain from collapsing when a single convoy was lost. The tents and tentage, the folding tables and the surgical lights and the sterilizers, the kerosene stoves and the blankets and the litters, all of this material had to be tracked and moved and maintained, and the quartermaster teams who did this work are invisible in the story but essential to its outcome, because without supplies the best surgeon in the world cannot operate. The enemy's impact on the chain was constant, not just through wounding Allied soldiers, but through actively targeting medical facilities. And the Geneva Convention's protections proved unreliable, German artillery sometimes honoring the Red Cross, and sometimes not. And the medical units learned to balance visibility and vulnerability, marking themselves clearly to avoid accidental fire, but dispersing to avoid being targeted deliberately. And the calculus was grim. How many wounded are you willing to lose to save the staff who treat them? And the answer was never clear, only situational. Some German units respected medical personnel and vehicles, some did not, and the variation was unpredictable. And the aid men and ambulance drivers learned to assess risk on the fly, to choose routes and timing based on intuition and intelligence, and they died doing it. Medics killed retrieving wounded, drivers killed in ambushes, nurses killed in shelled hospitals, and their names are on rolls of honor, but their stories are often unrecorded, subsumed into the larger narrative of the chains. Success. The collaboration between Allied nations extended beyond the battlefield into medical research and doctrine. British and American medical officers exchanging information, visiting each other's units, sharing innovations, and the result was a faster diffusion of best practices. Penicillin protocols developed in British hospitals, adopted by American units within weeks. Shock management techniques pioneered by American surgeons, teaching British counterparts. And the cross-pollination of ideas saved lives on both sides. Canadian medical units, part of the British command structure, brought their own innovations. Cold weather casualty care developed in the Italian campaign, techniques for treating frostbite and trench foot that became standard in the winter of 1944, and the integration of Canadian hospitals into the British evacuation chain added capacity and expertise. And Morrison's British counterpart benefited from Canadian nurses and doctors, just as Morrison benefited from American ones.